for that. I have a friend who's a family doc who is now full-time palliative care. And when I asked him about why, he just said, well, I like it, and a lot of my colleagues don't want to do it, and they started referring patients, and pretty soon that was all I was doing. And then I had a conversation with Phil Berger, who talked about the HIV, rise of HIV, and who in the city dealt with it before anybody really knew what they were dealing with, and he said it was all family docs. And yet I now see a kind of movement towards specialists becoming, it's like HIV is an infectious disease area that only infectious disease specialists should deal with, and we've got palliative care coming on as a specialty. And yet within the college you championed supporting our members who took on these areas of special interest. Can you talk a bit about how you see that balance?
So there is a significant menu of areas of special interest, and you're aware of that, and you've given a couple of examples that are very important ones, and they're all different, they differ. Yeah. There are areas of special interest for family physicians where there is very little debate about the fact that this belongs in the purview of a family physician and as part of the care they provide, and actually very few family doctors who have special interest in some of these areas are doing it full-time, but they are doing it for more of their time than maybe some others do. And we do need leaders within family medicine who help the rest of the family doctors to be able to actually maintain their competencies and have as a kind of mini referral colleague before the need for a Royal College full-time specialist actually is needed. And there are some of these areas that don't have Royal College specialties and many that do. This should not be a competition with the Royal College, and there's no need for that. There's lots of work out there and challenge for everyone. And most of those, even my colleagues who do full-time in areas like palliative care or in sport medicine or in any of the vast number of areas, they still refer to Royal College specialists where there is a Royal College specialty there, because they reach a point where they need to have that more complex case, which should be what the Royal College specialists are there for. But they provide that buffer in our system where access to care is such a problem, and we need to do more and do more at a higher quality level as a team of family physicians providing this. And I think even in the patient's medical home types of models that exist with team-based care, that family physicians with comprehensive continuing care practices and no real focus within their practice, because they spend all their time on anybody who comes in, should work together with some of their colleagues who have more focused practices and special interests, and provide better access to care before there's a need to send on to a specialist, but that will still happen. So I see in all of these areas, I see a very relevant role, and palliative care is an area that the reality is across Canada, the majority of the care provided for patients for palliative care is provided by family doctors, and it's going to be for I don't know how long into the distant future you can see. So we have to do something about being sure that at the core family medicine postgraduate training level, we are doing the job we should in preparing our graduates for having the competencies to be able to provide a lot of that care. And that goes for a lot of these other areas of special interest as well. Then there will be a subpopulation of those family physicians, either coming through residency or some who are already in practice, who we could offer something to where they could actually enhance their skills. And we could give a recognition of that. But they should not think that they have become Royal College specialists through this. They're not. The Royal College has a longer program that involves other goals and objectives within it than we have as family doctors. And the majority of them, whether they do the core family medicine or they do the core plus a bit more, I would hope that they would see the opportunity to do this as part of a broader based practice. Even if they do more palliative care or do more of XYZ than some of their colleagues, they work together as teams, they help one another out with their patients when they need the care in an area that a family physician with special interest has some extra skills that the other family physician doesn't, and perhaps that other family physician has extra skills in dealing with children with asthma that the family physician who does more palliative care doesn't, and they could benefit the patient and patient population at the center. And my belief is down the road this will have minimal impact on the need for Royal College specialists in all of these other disciplines. We'll still need them, but the people will be getting better care up front. And as a college, we should be supporting this and defining. We should be defining what we mean by special interests in family medicine and not leaving it to the community at large, the community of our family physicians who are not trying to do anything evil. They're trying to do something good, but they've had no context within which they make their decisions about how they should incorporate special interests into their practice. They have no idea of what they should really do to attain the competencies that would make them good at doing that, even if they do it as part of a broader based practice. That's what our college's role should be. But we should not be deceiving anyone into making it seem as though our main objective is to be training mini specialists or subspecialists. They should be family doctors.